Hello, everyone, and welcome to The Checkup, Crawford Memorial Hospital's brand new podcast. On this month's episode, we have with us Jamie Knoblett. Jamie is our oncology nurse practitioner here. Welcome, Jamie. We're happy to have you.
Thank you.
So I know oncology is not brand new to CMH. We've had it here before, but this is kind of a brand new version of the program. So tell us a little bit about what you do, what kind of patients you see, and what people can expect.
Okay. I work with Dr. Ahmed. He's a physician that comes down from Deaconess. I am here every day, Monday through Friday. He comes down 2 to 3 times a month and hopefully coming down more often. We do medical oncology. We also do benign hematology and malignant hematology. We have an infusion center here also. We can do your treatments. We can do chemotherapy. We can do immunotherapy. If you need iron infusions, we can do that here. If you see a specialist somewhere else, like a rheumatologist, and they prescribe infusions, you can get your infusions here. They can send the orders here. In our infusion center, we also, if you have a port, then we can draw your labs. We can flush your port so you don't have to go travel to get that done. And what we do in the office, as far as what diagnosis we see, we can help facilitate your diagnosis if you have a suspicious area or a mass. We can help facilitate to get that biopsied, whether we are able to do it here at Crawford or if we have to refer you out to another hospital. We work very closely with Good Samaritan Hospital. They do a lot of our biopsies there. Once we get your diagnosis of cancer, then you come back and meet with us, and we explain your diagnosis to you and come up with the best treatment plan for you and your family.
Of course, a lot of the cancer treatment, happens after the diagnosis, but there's a lot of people can do before the diagnosis, or a lot they can do to kind of prevent cancer. So talk a little bit about some of those things. Talk about screenings and lifestyle changes and some of those things that people can do.
Yeah, so we are our own biggest advocate, so we're in charge of our health. So we need to make sure that we're going to the doctor on an annual basis. We're getting routine wellness labs done. And if we meet the age criteria, we need to get our screening prevention, such as mammograms done, starting at age 40. Or if you're high risk, if you have a family history, then you need to work with your OBGYN or your PCP to see when you need to start your screening and what screening is best for you. You also need to start getting your colonoscopies for average risk people. That starts at age 45. If you have a family history of colon cancer, then that's going to start 10 years prior to your family member's diagnosis, or at age 40, whichever comes first. And it's important that we tailor your screening to your needs and your family history. So it is important that you follow up with your primary care doctor on a regular basis for that.
Why do you think some people are, because some people are so nervous to do that, or why do you think people kind of put that off or don't do those screenings?
I think a lot of people think that they're not at risk because they don't have a family history. But I think a lot of things are changing, and the environment, the foods that we're eating, I think that can make us at more risk. I think the prep for colonoscopies terrifies people. But there's other screening avenues besides a colonoscopy. You could do a Cologuard, which is a stool sample. That might not be a fit for everybody. If you have a family history or if you have any symptoms, that's not going to be a fit for you. But it's up to your doctor to decide what the best option is. There is a new colon cancer screening test coming out that's a blood test. I'm not sure if it's available here yet or not, but that is in the works.
Hope on the horizon then. People who don't want to do the colonoscopy.
Yes.
That's right. So you kind of talked about, alluded to this, but lifestyle factors, nutrition, and how important is that in cancer prevention, and what things should people be doing, or top 3 things people should be doing?
Yeah, we should all be eating a healthy diet. They just actually flipped the food pyramid. I don't know if you saw that, but we need to be eating whole foods. We need to be eating less processed foods. We need to be eating lean meats, fruits, vegetables, whole grains. So when we pick our bread at at Walmart, the thing I like to tell people is like wheat bread is just brown white bread. You need to get the bread with the nuts and seeds, the sprouts that you can see.
Right.
That is a whole grain. Instead of white rice, pick brown rice. Oatmeal's a good source instead of like, Frosted Flakes or
Right.
yeah. I tell people adults should not be, really anybody should not be picking cereal with the cartoon character on the box.
Tony the Tiger for us.
Yes. And I mean, along with nutrition, I mean, we need to teach that to our kids early to help prevent obesity. Obesity is a huge risk factor for multiple types of solid tumors. Also, exercise. We should be exercising. I'm not saying you have to go run a marathon, but go walk for 30 minutes a day. Start where you're at. I mean, don't compare yourself to other people. I mean, if you can just walk around the block for a week. Maybe next week you can make it 2 blocks, and then just set small goals for yourself. We need to definitely limit our sugar intake as well. And we need to teach that to our kids. We should be limiting sugary drinks. We need to be drinking water. We shouldn't be drinking sodas and even juices. And it drives me nuts that, the WIC program, which is not their fault, but the state program, they give you juice. Like, it's a free coupon you get. And so I think some people think, well, the WIC office gave it to me, so it's healthy for our kids. But really, no, I mean, you shouldn't be drinking orange juice. You should have the real thing, like have an orange or have grapes. Yeah. So it's just small things that we need to instill from an early age.
But I think that's kind of reassuring a little bit that it is small things and it's the common sense things too. I mean, you don't have to go out and overhaul your diet and, totally do things totally different. These are really doable changes, I think. I mean, that everybody can do. Yeah.
Obviously, the biggest one would be smoking, stop smoking. So if you do smoke, it's just important that you work on quitting. I mean, obviously don't start, but if you are smoking, you will reduce your risk by quitting smoking.
What about vaping?
Vaping is just as bad or possibly worse than smoking. Vaping is not a tool that we use to help people quit smoking.
Yeah. Let's talk a little bit about early warning signs. So I know there's a lot of cancers or whatever that don't have symptoms or don't have things, but what are some early warning signs that people shouldn't ignore? If something's wrong, you know what I mean? What should they be seeing the doctor about?
Yeah, if you feel any new lumps or bumps anywhere, you should definitely get that checked out. You should be looking at your skin every day, looking at any moles that you have or freckles, make sure they're not changing. If you're over 30, you shouldn't be getting new moles or freckles. If you do have a skin lesion and it's bleeds and comes back, should be checked out. We should be wearing sunscreen, which I know is wasn't part of your question, but since we're talking about skin, like when you're outside, we should, 1 ounce of sunscreen to exposed skin every 1 to 2 hours is very important as a preventative measure. If you have any new rectal bleeding, you need to get checked out. If you have any new vaginal bleeding and you're postmenopausal or menopausal, you need to go get checked out right away. If you have a chronic cough that's not going away, if you're coughing blood up, then you need to get that checked out. If you're having, headaches, constant headaches, you should get that checked out. I mean, it doesn't mean you have cancer, but definitely a warning sign. You should be checked out.
Yeah, I mean, always call your doctor. Better safe than sorry. I mean, because you did family practice for a long time or for several years. Yeah. I think people think, well, I don't want to bother them, or what if it's nothing? But they don't care.
Right. We absolutely don't care. We would rather catch something in an early stage. Oh, blood in your urine. Sorry. I had to throw that in. Blood in your urine is a big one too. But yeah, I mean, the whole point of seeing our primary doctor is we want to prevent cancer from happening. But if we can't prevent it, we want to find it in the earliest stages. So it's better to get checked out. No healthcare provider is going to think you're dumb for coming in
right.
for anything.
Yeah, but I think people do worry about that. I think they think, oh, I don't want to bother them, or it's just a cough. They're going to make fun of me. But no, absolutely not. They never would.
Right. I know, I'm a nurse. We're the worst patients. So I understand.
I've always heard that. That's true. Talk a little bit about, so let's say I'm not the one with cancer, but it's a family member or someone a friend. What can I be doing to support that person better?
Yeah, I think just being there is important. I think listening to them, offering support, whether it's if they need rides, if they need meals cooked for them, is important. But we can't fix the problems. I think it's our human nature. Like we just want to fix stuff and make it better, but there's nothing we can do. But we can listen to them. We can be their advocate. If they're afraid to speak up for themselves or ask questions, we can help them. If they do have questions or concerns, we can write it down for them. We always encourage our patients to write it down, but sometimes they might not feel well, or they'll say, well, we'll do that later. So you could take some initiative. Let's start a list and we'll bring this to your appointment.
Yeah, I think that's good advice. I think sometimes the patient's so freaked out a little bit hearing they have cancer that maybe having someone there to kind of be your eyes and ears is probably a good thing. We were talking a little bit before we started recording about the different stages of cancer and how people maybe don't understand that. And I think especially if you're hearing for the first time you have cancer, the rest of it might just be a blur or a word. So talk a little bit about what that means and how a patient should approach it or a family member should approach it.
Yeah. So whenever we let you know that you have cancer, we will, look at the different stages. And sometimes that might take multiple visits. You'll have to get a biopsy. You may have to get CT scans, blood work to be able to tell what stage you're in. But there's early stage disease, and then we can find cancer at later stage disease. Early stage disease, usually depending on the cancer, can be curable, meaning we can get rid of the cancer by either chemotherapy, immunotherapy, or a combination of radiation, surgery, chemo, or immunotherapy. And then for advanced stage cancer, most often it's not going to be curable, but with the latest technology, we're making changes in medicine every day, especially in the oncology world. You might not have curable cancer, but we have turned cancer into a chronic disease. So it is important to find out with your treatment plan what the goal is. So the goal, is it going to be curative or is it going to be palliative, meaning we're going to try to shrink your cancer as much as possible and help maintain your quality of life with it.
You talked a little bit about technology, but tell me a little bit, because I know, in earlier iterations of your career, you were an oncology nurse. Tell me a little bit about how cancer care has changed with technology and what kind of new advances that we see today.
Yeah, we've really came a long way in looking at genetics, like genetic makeups of tumors, different biomarkers, and certain biomarkers can change what type of therapy we use. Chemotherapy used to be a mainstay of cancer treatment, which is scary and can come with a lot of side effects. And now, we still do use chemotherapy a lot, but we do have the ability to do different testings of your cancer to see if you qualify for immunotherapy or different types of targeted therapy, meaning targeted therapy specific to your tumor type and makeup.
So what you're saying is the testing we can do can kind of better identify the makeup of the tumor so we can pick a therapy that targets it a little better, maybe isn't just throwing everything at the wall and hoping something works, kind of, right?
Yes.
Basically. It's just amazing how far things have come. And because you used to hear it was just awful, and it's just wild to think how things have come.
Yeah.
What do you see as the biggest, and maybe that's it, but what do you see as the biggest change or the most exciting thing in cancer care? Like since you were in it earlier or coming down the pike?
I'm not sure. When I did it as a nurse, I did mostly malignant hematology. So I was inpatient. I did stem cell transplant. So it's a little bit different. Now I do a little bit of everything as far as solid tumors are completely different than that. But I think just the different surgical techniques we have, they can be a lot less invasive. We don't have to open people up as much.
And I was thinking, because you did cancer care as a nurse, and then you did family practice for a while as a nurse practitioner, and then you're back. What kind of made you jump at this opportunity, or what brought you back to oncology and hematology?
I will tell you my story, but you're probably going to think I'm crazy afterwards. I lived in St. Louis and I worked at the Siteman Cancer Center at Barnes Jewish Hospital, and I worked on the BMT floor, which is bone marrow transplant or stem cell transplants. I loved my job. I mean, I look forward to going to my job every day. I felt like I made such a difference in patients' lives. My husband got transferred back here. That's why we moved. At the time we were living in Newton, but I drove back and forth for 3 months because I loved it so much. I had small kids, so that wasn't a long-term solution. And I mean, one day on the way home, my drive home from St. Louis, which was a 2-hour drive, I was talking to one of my friends and I was just cried the whole way. Like, why would God give me all of this education and teach me all of this just to take it away? And then I came here to work in OB, which is just completely opposite. And anyway, I was very dramatic and I was like, one of my kids is going to get leukemia and just, off the rails. And of course, she talked me off of it. But I just think when this opportunity came up, I don't think anybody remembered that I had an oncology background. And I was like, hey, I am your person. Like, I want to do it. And I just think it's a full circle moment for me, and just believing that God has a plan for our lives. And I do think this is, I mean, everything happens for a reason, and this is it. Like, this is perfect. Yeah. And we have a really good team here. And obviously, I love working at CMH. I've been here for 10 years, and I'm just happy to be able to do it in my hometown. I was born and raised here. So I'm very happy to be able to give back to my community. It does make it a little more emotionally challenging for me because I was raised here. And I did family practice for 10 years here. So I know a lot of people. I know most of my patients. So that has been a little challenging, but I definitely think it was my plans.
Yeah, it's what you were here for, put here to do. Yeah, for sure. That's such a wonder. I mean, that's really, really heartwarming. I mean, that's really
embarrassing to say.
I think it's wonderful. I mean, I bet that's so... That's just, I don't know, it's just such a nice story. So touching. It really is. So we talked a little bit about nutrition, how important that was in prevention of cancer. But I know it can also be, like, if you're actively undergoing treatment, nutrition plays a huge role. Talk a little bit about that and some of the misconceptions that people have.
That is the number one question I get, and especially from family members. They get very concerned about their loved one, maybe having a decreased appetite and not being able to eat. So it's super important not to go on the internet and find some crazy diet to help cure your cancer. We do use diet and nutrition to help with your treatment, but we can't cure cancer with nutrition. We can definitely help it incorporate into our treatment plan. If patients are wanting to eat a lot, we're not going to force feed them, but when they do eat, we want it to count. So we want to have high protein foods if possible to help with healing. And I guess also, if patients are going through treatment and they're not hungry, like, just give them whatever they want. I know they're like, that's sugar. And a lot of people say, well, I hear sugar feeds cancer. Well, I mean, yes, it does to an extent, but we're not going to cut you off from sugar. I want you to have some nutrition over zero nutrition. You have to have nutrition. You have to have calories to support your body. And really, at the point where we have cancer, it's kind of too late to worry about our sugar, because we probably had too much sugar and too many processed foods prior that could have contributed to our diagnosis. So yes, we want to eat healthy, but if patients aren't wanting to eat, we want to give them whatever is going to help them to get food in. So that is very important. But I just see a lot of people really, go off the rails and find the internet diet that's going to cure their cancer. And please don't do that. Support your loved one. And if they're, if they ask for something, get it for them. I don't care if it's a piece of chocolate cake. And I'm a huge advocate on eating healthy. But we just want to support them and get in any calories that they can.
Because a lot of times, I know when my mother-in-law was going through cancer treatment, she was just wore out. I mean, she was just so exhausted. So that probably speaks to keeping calories in them. But what other kind of things can you do to help kind of manage that fatigue and that draining that cancer treatment has for patients?
I don't know of any cancer patient I mean, I could be wrong, but I'm, studying for my certification. And that was even in my mock board test that, 100%, I think it was worded that 100% of cancer patients complain of fatigue. Mm-hmm. Now, whether it's because they know they're getting treatment or are they really tired? But the best way to help combat that is to exercise. And again, don't go sign up for a 5K. Yeah. Go for a walk. Even if you have to walk laps in your house, just move your body. Mm-hmm. It's also super important to keep a routine. Having cancer can throw our whole schedules off, not just the person, but their families. But we have to keep a routine. That's going to help with fatigue. It's going to help with chemo fog or chemo brain. And exercise is important too.
Almost counterintuitive because you think, oh, I'm so tired, I just want to rest. But how does exercise help, or why is that such a good tool to use?
And yeah, I mean, anytime I exercise, it just makes me feel better.
It does. I mean, myself too. Like about a day you spend Sunday on the couch, you're like, well, if you get out and go for a walk, you're a lot better off than just, yeah.
Well, one thing I like to tell people in primary care, I love to exercise. I exercise 6 days a week, but I have never regretted an exercise. So I say, if you're tired, you don't feel like doing it, go for a walk. And after 10 minutes, if you're still mad about it, go home, quit, or stop. But I have never stopped. I shouldn't say never. I stopped one time after 10 minutes, but that's because I was sick and I felt like I was going to vomit. But
that's probably a good excuse. Yeah.
But I walked 10 minutes out and then I had to turn around and come home. So I still got 20 minutes.
You hear people go through cancer treatment and, when they come out on the other side, like the survivorship of it, what happens? It's such a big part of their life. Kind of what happens then, or what do they need to be looking out for, and how do they manage life after cancer?
Yeah, that's a really good question. I mean, we'll usually follow you for several years after your cancer, but even during your cancer treatment, survivorship starts at diagnosis. So at the time you're diagnosed, we start your survivorship plan, no matter what stage cancer you have. And it's actually, we have a document that we create that puts on there the stage of cancer that you have, your biopsy results, any genetic markers, biomarkers that we talked about, what your treatment was, where you received your biopsy in case we would have to look back later, and the plan going forward, like what you need to have done, like once you're released from our care. We keep that document in your medical files here, and we also forward that to your PCP. We also give you a copy, which is super important because if you have to go to the ER, you might not remember all of the correct terms, medical jargon, but your ER doctor would want to know that. Or if you have to go see a specialist for like a rheumatologist or anybody, it's good to know, to have exact information of what medications you took. Or if you move and have to go somewhere else, I mean, some chemotherapies, there's lifetime doses. You can't have more than a certain amount. So I think that's very important. When I did primary care, I don't recall ever getting one of those survivorship plans from a patient. And I think it's great for continuity of care, especially here. I am in close contact with PCPs, the surgeons, even the other specialists we have here. So I think that's huge. And my nurse navigator, Bridget, has worked really hard on these survivorship plans. It's something I'm very passionate about, especially I think, because I was on the other end of it. I have these patients, well, you're released from your oncologist. Well, what do I do with you now? I mean, family practice has to know a lot and do a lot. So if we can simplify it for them and for the patients and family members too, just to have that, living document that we kind of update throughout your treatment.
Okay, so our last question before we wrap up. If I gave you a magic wand and you could, make sure everybody knew one thing, what would it be? You have cancer patients, non-cancer patient. You wanted everybody to know one thing about their health. What would it be?
You're in charge of your own health. You're responsible for your own health. I mean, and prevention is key. Like we talked about, diet, exercise, following up with your primary care doctor at least once a year. Those are key. Don't be afraid of your doctor. Don't be afraid to tell your doctor or nurse practitioner, PA, whatever, your healthcare provider. I keep saying doctor. Don't be afraid to tell them anything. You have to be honest. If you're not honest, you could possibly delay your care, whether it's, for cancer or not cancer. You can make things worse too, if you're not honest. Like we all do things we're not proud of. We all have, if you used to smoke, you got to be honest about it. If you still closet smoke, you got to be honest about it.
I mean, you're people too. Everybody makes mistakes, and you're understanding about it. Yeah.
And it's I mean, we can't help you if we don't know everything that we need to know. So if we ask you questions, be honest.
Yep. I think that's good advice and the perfect advice to end on. Jamie, thank you so much. We appreciate your time today, and we'll have you back sometime soon.
Oh, great.
All right. Thanks everyone for listening.